Next up is Dr. Leslie Kobayashi. Now, Leslie, I met briefly when I was at LA County. She did a residency at LA County USC. But Leslie then was hired by us as one of our trauma surgeons. And Leslie, when it's business, Leslie's all business. And so you're going to get a very concise, up-to-date talk of the latest state-of-the-art of the problem of anticoagulants and trauma patients. But don't come away from this thinking that that's the way Leslie is. Leslie has a humorous side as well, and a pretty sharp wit, so that may come through now and again. And I'm going to get out of here before I get in any more trouble. So, do you want something? Oh, you forgot something up here?
Yeah, sorry.
Phone, that'd be useful. All right. Now, don't run away after the session. We're going to have a break, but you know, being who we are, we try to make sure you have a good time and go the extra mile. So we're going to be raffling away some prizes, and so I think folks may have some tickets. Paying customers probably have some tickets on the back of their. I don't got one, but some folks do. And if you've got a coupon or number in there, just keep track of that, because our nurse is going to come by and pick out some numbers. If you're one of the lucky ones, you might win a prize. We're giving away some nice bleeding control kits and some tourniquets and things like that. So hang on. But Dr. Kobayashi is going to go up now.
Good morning, everybody. Last talk before the break, so I apologize for the length of it. We're going to go to the exact opposite end of the age spectrum now, from going to the children all the way over to the primarily geriatric population of our trauma patients, and I think a lot of us are seeing many of these patients. I'm going to focus today specifically on novel oral anticoagulants, particularly about their effect on traumatic brain injury in our trauma patients. I have no disclosures. So anticoagulation and trauma is a known association. There are a large number of patients on warfarin or aspirin, Plavix, antiplatelet agents, and that population has increased significantly over time, both with the increasing incidence of diagnosis of things like atrial fibrillation, DVT, and PE, as well as with the overall aging of our general population in the United States. These traditional oral antithrombotics have been associated with very poor outcomes following trauma, including increased intracranial hemorrhage rates, increased rates of progression of the intracranial hemorrhage, and overall worsening mortality. Recently, some new agents to anticoagulate our patients have been approved by the FDA and are at large in the market. Between 2010 and 2015, the agents dabigatran, rivaroxaban, apixaban, and edoxaban were all approved by the FDA for the treatment of both venous thromboembolism as well as for stroke prevention in patients with atrial fibrillation. You can see in these two slides here the mechanism of action. So rivaroxaban, apixaban, and edoxaban are all specific anti-10A inhibitors. Dabigatran is a specific thrombin inhibitor. And in the coagulation pathway, the anti-10As specifically block propagation of the clot, whereas dabigatran or Pradaxa blocks fibrin formation and really strengthening of the clot once it's beginning to form. The safety profile and efficacy of these novel oral anticoagulants is overall extremely favorable when looking at randomized controlled trials compared to warfarin anticoagulation. Routine monitoring and dose adjustments are also not currently recommended for patients on the novel oral anticoagulants, which I think to many of our primary care physicians and cardiologists make these agents very preferable in that the patients don't have to come frequently for lab monitoring, blood draws, frequent redosing of their Coumadin. It's basically just one dose for the majority of patients on these drugs. Additionally, they don't require any bridging, so patients can be diagnosed with a PE DVT in the emergency department, and they don't need Lovenox injections, pharmacy approval for outpatient injections, teaching. They can just be given a prescription for a pill and go straight out back to their homes. However, we have seen multiple studies that demonstrate the serum drug levels of these unifunctional dosing drugs can vary greatly in real-world populations. Some of the factors that really impact the amount of serum drug levels in our patients include advanced age, gender, their creatinine clearance, and if any of these drugs are given with statins or diltiazem, which we know occur quite frequently in this elderly population. Additionally, we know that increased serum drug levels of at least dabigatran have been associated with a significantly increased risk of clinically significant bleeding. However, despite some concern, novel oral anticoagulants, including Pradaxa and the anti-10A inhibitors, are currently recommended as the first line of therapy for both atrial fibrillation and venous thromboembolism by the American College of Chest Physicians in their 2016 guidelines. This is probably going to result in the number of patients on these novel agents increasing significantly. However, there have been a number of publications, both in the medical literature as well as in the lay press, all leading to significant lawsuits related to major and catastrophic hemorrhage in patients on these drugs. So, do we really know anything about the effect of these novel agents in trauma patients in a real-world population? Some of the questions that we were concerned with at UCSD were, can these novel agents be detected in our trauma patients? As we know, many of our elderly patients come to us obtunded or confused, either because of underlying dementia, neurologic conditions, strokes, or as a result of their injury or shock, and cannot answer questions as to their current medications. Many patients just don't remember what they're on. Also, are these novel oral anticoagulants associated with increased rates of intracranial hemorrhage, with progression of brain injury, or with death, similar to the effects of warfarin, aspirin, and Plavix in trauma patients? So to answer this question, we decided to start a multi-institutional trial, the objective of which was to study the injury patterns and outcomes among trauma patients on these novel oral anticoagulants and compare them to patients on traditional oral antithrombotics like aspirin, Plavix, and Coumadin, which we're more comfortable treating and have a better understanding of their impact on trauma. The study design was a 2-year prospective multi-center observational study sponsored by the American Association for the Surgery of Trauma and their multi-institutional trials committee. We included all patients admitted on either warfarin, aspirin, Plavix, dabigatran, apixaban, or rivaroxaban. Edoxaban wasn't included because at the beginning of the trial it had not been approved. We included basics of demographics, mechanism of injury, vital signs, outcomes, labs, interventions, length of stay. Our specific outcomes included rates of intracranial hemorrhage, rates of progression of intracranial hemorrhage, and overall mortality. The results of our first pass of the study, so the first 2 years of data collection, we had 16 centers participating. The average age of our patients was about 75, which was expected. It was about a 50-50 mix of female to male, overwhelmingly Caucasian in race, an overwhelming number of patients had at least one comorbidity. 99% were blunt mechanisms, so penetrating mechanisms, very rare in this population. And not surprisingly, the majority of these patients were presenting after a fall, with motor vehicle accidents being the second leading cause of injury. The median ISS of these patients overall was low to moderate, about 9, with interquartile range of 4 to 14, and this included almost 2,000 patients. This is the breakdown of the types of agents. So you can see, that relatively few patients, only about 10%, were on the novel oral anticoagulants, with the majority of patients being on either antiplatelet agents or on warfarin. So showing a little bit of a lag in terms of what people are actually prescribing at this time compared to national guidelines for treatment of VTE and AFib. So the first question, can these agents be detected in our trauma patients? So there are some pharmacological studies in healthy volunteers testing conventional coagulation assays like PT, PTT, INR, as well as thromboelastography pre and post administration of these drugs. And there are some suggestion that there are modest elevations, primarily with dabigatran in healthy volunteers after administration of the drug, but potentially some consistently mild elevations in the R time on TEG in patients on the anti-10A inhibitors. We wanted to know if this was reflected in our patients in a way that we would be able to obviously identify coagulopathy associated with these drugs. So can conventional coagulation assays or thromboelastography detect this coagulopathy associated with drugs in our trauma patients? Unfortunately, the answer to this appears to be no. So as you can see here, there's a mild tendency toward the higher end of the normal spectrum in PTT, in dabigatran patients, in a mild elevation toward high normal of their INR as well, but really no difference in terms of normal values for INR, PTT, or any effect of correction with FFP, cryoprecipitate, or prothrombin complexes. Additionally, looking at TEG, which should have been slightly more sensitive, unfortunately, again, no real elevations in the R time were noted. The normal value for UCSD's thromboelastography for R is between 5 and 10, and you can see here for dabigatran, rivaroxaban, and edoxaban, all the R times were firmly in the middle of the normal range, if not skewed slightly toward the more hypercoagulable rather than coagulopathic end of the spectrum. Additionally, again, no difference at all noted pre and post attempts at reversal of these agents. So conclusion here, unfortunately, neither the conventional coagulation assays nor thromboelastography were really able to detect either any clinically significant coagulopathy nor any actual therapeutic impact of any of our attempts at reversal. We do know that there are more effective tests to quantify the extent of anticoagulation associated with these novel agents, particularly for dabigatran, eccrine clotting times or eccrine chromogenic assays, which unfortunately are not widely available, and for rivaroxaban, apixaban, and edoxaban, drug-specific anti-10A levels, which are widely available, though I think currently utilized. So my recommendation is if you have any of these labs available to you in your institution, that you start sending them on patients known to be on any of these agents, because they should be more sensitive at detecting the presence of the drugs, quantifying the extent of the coagulopathy associated with these drugs, and hopefully with some time and a number of these lab results, we can start trying to draw some conclusions as to whether or not their levels are associated with outcomes that we're interested in, like rates of hemorrhage, bleeding, need for surgery, and mortality. Next, are these agents associated with increased rates of intracranial hemorrhage? So we can see here the oral antithrombotics like warfarin, Plavix, and aspirin compared to the novel oral antithrombotics. This shows that overall their demographics are fairly similar, their rates of shock slightly different, with the rate of shock on presentation being slightly higher on univariate analysis in patients on the NOAs compared to the more traditional agents, but the rates of intracranial hemorrhage are statistically significantly lower on univariate analysis, only 24% in the novel oral agents, whereas it's 31% on the patients on aspirin, Plavix, or Coumadin. However, after we correct for injury severity, GCS, ISS, and procedures, the statistical significance was trending toward significant, but did not reach statistical significance. But a possible indication that these agents may not be as bad, and certainly they are not worse than the traditional anticoagulants in terms of rates of intracranial hemorrhage. When we look at the outcome specifically by drug, interestingly enough, we found that the agent most dangerous for our patients in terms of intracranial hemorrhage was surprisingly aspirin, with the NOAs being significantly lower. The rates of need for neurosurgical intervention, any significant complication, hospital and ICU length of stays were not at all different between the drug groups. And this increased risk ratio was maintained for aspirin compared to all other agents, even after correction for demographics, mechanism of injury, and injury severity. The distribution of intracranial hemorrhage, again, was not different, so it's not that the aspirin patients are presenting with much more mild forms of head injury, or that the warfarin patients are presenting with larger injuries. The patterns were pretty much the same throughout. So, are NOAs associated with increased rates of progression of brain injury among the patients who do have hemorrhage? Again, looking at the demographics, relatively similar, length of stay, similar. Overall, the rate of progression was fairly high, about 20% in both groups, but not significantly different between the traditional agents and the novel agents, either on univariate analysis or on multivariate analysis after correction. Again, looking at the different agents specifically, no statistically significant difference. And lastly, and most importantly, I think, are these agents associated with increased rates of death? So again, demographics similar, shock slightly higher in the novel oral anticoagulant group, but rates of head injury slightly lower, progression similar, and here rates of mortality of the overall population not different at all, 7% and 7%, and among those with TBI, no difference there either, 15% in the traditional agents and 12% in the novel agents. And again, this was maintained, no statistically significant difference either in overall population or among patients with brain injury for the novel agents. Looking at these other outcomes by specific drug, overall everything was relatively similar, with the one exception that patients on Coumadin were more likely to be reversed than any other agent. And I think this is probably because we have INRs, which provide us a quantitative measure of the amount of coagulopathy and a known reversal agent in FFP and or prothrombin complex. Again, no difference in the rates of death by specific drug either. So in conclusion, among this population of anticoagulated elderly patients, we were unable to detect a higher rate of intracranial hemorrhage, and if anything, a possible benefit to the patients on the novel agents compared to those on aspirin, Plavix, or Coumadin. No difference in progression of intracranial hemorrhage, and no difference in overall death or in death among those with traumatic brain injury among patients on the novel agents. This study does have some limitations. It was observational, not interventional. There was no true control group of similarly matched elderly patients who are not receiving any type of anticoagulation. And again, there was a relatively low number of patients, only 10% of the population, on the novel drugs. So ongoing studies are going to be needed to confirm any of these outcomes. So back to our questions. Can these novel agents be detected in our trauma patients? The answer to that is unfortunately no for conventional assays and likely no for thromboelastography, but potentially yes if your institution has more drug-specific assays. Are NOAs associated with increased rates of intracranial hemorrhage? Seems like no, and there's a potential protective effect of these agents compared to compared to the traditional antithrombotics. Are they associated with progression of brain injury? Nope. And are they associated with increased rates of death? And that fortunately is no as well. These are the centers that I would like to thank their participating primary investigators. Happy to answer any questions.